Hello, and welcome to the Body Fusion Therapy Podcast. I'm your host, Dr. Heather Demirci. We are starting off the visceral mobilization series with talking about the stomach and the esophagus. So in today's episode, and kind of in the subsequent episodes that we're going to be talking about specific organs, we're going to look at first, where is the organ located? Now, we're just going to talk about kind of general facts on it, not getting too specific, but just kind of get a general knowledge of where that organ is. So we're going to talk about that first location, and then we're going to talk about the different pathologies or kind of what would warrant mobilizing the organ. Now, I talked about how mobilization of an organ can actually improve the function of the organ. So I am going to talk about what sort of pathologies that you would see from like a medical standpoint of what would warrant wanting to mobilize these organs. But then also I'm going to talk about it from the musculoskeletal route, about how that fascia around the organ, if it's not moving properly, that it will be limiting mobility or strength of your musculoskeletal system. So we're going to talk about what sort of findings that you would see if you had restrictions around the organs. And finally, we're going to talk about how to treat it, how you can kind of treat it on your own. Because like I said in that episode I did before, we're going to kind of talk generally about what visceral mobilization is some of this is actually really safe for you to do, where you can kind of mobilize the organ yourself to try to get improvements. And I have done that by teaching telehealth to people, where kind of showing them where they need to mobilize and what sort of directions. So I feel comfortable with these organs kind of talking to you about how I would treat it and how I would have you treat it as kind of a home exercise program. So we're going to talk about the stomach and esophagus today, where that's what we're starting off the series with. So where is the stomach and esophagus? Well, let's start with the esophagus. So the esophagus is where you swallow from your mouth and the food goes down into your stomach. That's what the esophagus is. But it doesn't start right in the back of your throat. It actually starts in front of your sixth cervical vertebrae. Now, that probably means nothing to a lot of you, and that's totally fine. But if you were to look at the front of your neck, kind of where you have that divot in where it's the start of your breastbone, just right above there, and if you went straight back, would be your C6. So the esophagus actually starts lower down. It doesn't start high up, like right where you swallow. And it's sitting between your trachea or your windpipe and the cervical spine. So it's kind of sandwiched between the two areas. And with that kind of comes its own series of dysfunctions, right? Anytime you have an organ that's sandwiched between two areas, that could be a sign of potential problems, right? The very narrow space that it's able to move in, there could be issues there. Now, the esophagus starts at that C6 area, that sixth cervical vertebrae, and it goes down into your rib cage, and it ends just to the left of your ribs at the seventh rib is actually where the esophagus is entering into the stomach. Now, that doesn't mean that's the top of the stomach, though. So the top of the stomach is actually, which a lot of people are surprised about, is pretty much at nipple line. So it's between your fifth and sixth ribs. Now remember, the esophagus ends at your seventh rib, but the top of the stomach is at your fifth or sixth rib, that space in between. So that means that the stomach actually comes up higher. So it comes up higher to the left. So where the esophagus is entering into the stomach is just to the inside of it and a little lower down, and then it kind of comes up and around and goes down. Now, everybody, I guess I shouldn't say everybody because there's always those anomalies. But I'd say 99.9% of people, unless there's something, other congenital deformity going on, the stomach is starting at the same level. It is starting at that space between the fifth and sixth rib for everyone on the left-hand side. Now, where it's at the bottom, that's a little different. That can really vary between people. For the majority of people, if it's efficient, it is actually the bottom of it is at the end of your belly button. So right across the line of your belly button, if you drew a line over to your left-hand side, that is where the bottom of your stomach would be. Now, there are different kind of positions of the stomach. So some people have their stomach be really high. So it's actually higher than that level. Some people are down below that level. I always say, that person that their stomach is a little sitting lower if whenever they eat, their stomach just gets really big, like they can't hide it. My mom would always joke growing up that you always knew after I ate because my stomach would just be really big and I couldn't suck it in no matter how much I ate. And that's because naturally my stomach just sits a little bit lower. So it's still starting at that fifth, sixth space, but then it goes down a little bit lower. And people that are really, really sick, it will be way down lower, like into their pelvis lower. Those people, that would be what we call an atonic stomach. So it doesn't have any tone or any kind of muscle play. Those people are extremely, extremely sick though. So it's very rare that you would have an atonic stomach or a stomach going down that far. Now, there could be some adhesions that are pulling things down a little bit, but if you have an atonic stomach, you are really sick. You just can't really digest food. You're not really hungry at all. And it's just because there is no tone in your stomach. So it can't actually move the food to kind of create the sludge that then will go into the rest of your intestines. So just be aware that it is more common that you're going to have the bottom of your stomach ending at the line of your belly button. If you drew that line from your belly button over to the left-hand side. Now, the stomach has a curvature. It has a greater curvature and a lesser curvature. So the greater curvature is actually considered the outside of the stomach if you're towards your left-hand side. So that line going down, starting at that fifth, sixth space and going down and around the stomach, that is the greater curvature, because the lesser curvature is towards the inside, to like more the midline of your body, and it is smaller. It's called the lesser curvature. The lesser curvature is going to come important when we talk about treatment a little bit later. But there's greater curvature or lesser curvature. That means just the sides of it. So the right side of it would be the greater curvature. The left side of it would be the lesser curvature. And that's the position of the stomach. Now let's talk about different pathologies. So I want to talk about first, why would you treat the stomach if it was coming in for something other than musculoskeletal issues? So like I said in my previous episode, about 20% of my patients come into me specifically for mobilization of the viscera. Now, 99% of them end up getting some one organ treated at least during the total plan of care and treatment that they're with me. But about 20% of them come in specifically for visceral issues. So people that would be coming into me specifically for this are people that have really bad acid reflux, or what we call GERD. So you can actually help with GERD. Sometimes it's just that the esophagus is really shortened. And so you want to be able to stretch that esophagus. And it's not that it's congenitally shortened. There are people that have that dysfunction, but that there's adhesions of the fascia around the esophagus that are making it in a shortened space, and that can be affecting the acid reflux. So I'll have people come into me that have really bad acid reflux. I'll have people that had ulcers, either esophageal ulcers or stomach ulcers, gastric ulcers. They'll want to come in and get everything mobilized because there's a lot of inflammation that happens with that. Whenever there's inflammation, then becomes adhesions. If you go back to when I talk about how do scar tissues form, that one of the ways is inflammation. So any sort of inflammatory process with an ulcer would cause that. Dietary irritants, same sort of idea. Any sort of inflammation you have in through your system because of diet, you would want to have your stomach and esophagus mobilized. What about if you had a hernia, or what's called a hiatal hernia? Now, a hiatal hernia, there's two different types, a sliding hiatal hernia and a non-sliding. So sliding is 95% of the cases. So those are people that actually have a hole a little bit too big in their diaphragm where the esophagus is going through to enter into the stomach. And so then part of the stomach actually can go up in through past the diaphragm. Not a lot of it, but a little bit about it. And those people, it's usually moving up and down. With those people, they probably have GERD as well, that have that acid reflux. So if you've been told you have a hiatal hernia, you can get treatment from it doing these visceral techniques. Now, people don't usually know or find out that they have a hiatal hernia unless they get diagnostic imaging. It's something that's usually picked up as just kind of like oh, by the way, did you know you have a hiatal hernia? It's not something that they really go looking for a ton. It's just kind of usually a little artifact that they see in the MRI or CT scan that you might be getting for. Could be something else. I've had patients that have realized that they have it because they were went in for low back pain, or they went in because they were having some ribs issues. And then they found out on the MRI that they had the sliding hiatal hernia. Now, other things you might come in for if you had really bad whiplash. So this could be from a car accident, or this could be from kind of a sporting event, or just something that you got a big whiplash in your neck. Now, the reason why this is important is because remember where I told you that esophagus is sitting? It's sitting in between your windpipe or your trachea and your cervical spine in your neck. And when you get a really big whiplash injury, you'll actually get micro tearing of the outside of the esophagus. And that outside of the esophagus will start to bleed just a little bit, not a lot, but just a little bit. And with that blood is going to be coming in this patchwork of fibrin to try to scar everything down. So I've had patients that have had repeated whiplash injuries that their esophagus is actually scarred down to the front of their cervical spine. So sometimes that's what's causing their neck issues, is actually this adhesion between the esophagus and the cervical spine. If you remember to the hierarchy of the organ systems, that digestion is way more important than your neck pain. So it's not going to occlude or kind of close down your esophagus by putting you in a position of your neck where it's more comfortable. It's rather that it would have that esophagus nice and open so you can get food and nutrients so you can continue to survive. So sometimes that whiplash injury has a huge impact on the esophagus, especially. It can also cause the stomach to go up as well, but more often than not, we see issues with the esophagus with a whiplash injury. If you also have a history of vomiting, now this could be that you had a period of time where you had really bad food poisoning. It could also be that you have a history of bulimia. Or it also could be pregnancy. You know, I had really bad morning sickness with my daughter, and I was throwing up 4 to 5 times a day for about the first 4 months. And so I definitely had a lot of stomach restrictions because of that forceful motion upwards when you're trying to expel the food in your stomach. That can lead to dysfunctions of the esophagus and the stomach as well, where it's kind of getting held upright too much because of this forceful motion that you've done repeatedly. I had a patient in the past who he had this shoulder issue, this shoulder pain, and we brought it all back to he had this period of time in high school where he was vomiting violently to the point where he had to get hospitalized twice, I believe, to get fluids. And they never figured out why he was vomiting, but then his shoulder started bothering him later and continued to bother him for years. But really it was getting that stomach to mobilize down again that was able to free up the shoulder so that it could move more effectively. So that kind of brings me in a little bit to what you would be finding in more of a musculoskeletal range of motion issue that might warrant having a stomach treatment. Well, for the stomach, it could be limited left shoulder mobility. More specifically, going out to the side, trying to almost like doing a snow angel, lifting your arm overhead. Because of the rib cage needs to be able to expand and move as your arm goes up as well. It's not just your shoulder that's moving. You're also having motion of those ribs. But if the ribs are kind of held down because of adhesions of the stomach inside the rib cage, because remember, the start of the stomach is at nipple line. That's not too far away from your shoulder. So if all those ribs are being held down because of adhesions of the stomach, then they're not going to be able to go upwards and kind of move for good shoulder range of motion. So people that have limited shoulder, what we call abduction or going off to the side, I would definitely be looking at stomach, especially if I saw that their rib cage wasn't moving very effectively. Now, you can also test this out by trying to side bend. So trying to bring your right hand down the side of your body and see how that left side of your rib cage expands. If it doesn't expand very well, there can be a stomach issue. And also if you go into left side bending, maybe that stomach can't go down, and that's what's limiting that you can't side bend as much to the left. So you want to see what is it that's underneath that area that's not moving right and what organ that could be associated with. So with restrictions of the shoulder and with side bending, where it's more feelings on the left side of the rib cage, it's probably stomach you need to be going after. You will also find limited rotation of the neck if there's a stomach issue, because it's going all the way down. And as you rotate your head, everything should be able to rotate. So especially if there's esophagus restrictions, you won't be able to rotate your head as far. That also goes with not being able to look back either just from the neck or also going into extension of your thoracic spine or trying to back bend. If you're not getting much motion through that rib cage and really being able to extend through there, and what's more coming from the low back, then I'm thinking what's happening within the rib cage that's not able to move. And also what you'll be finding is in the neck, they won't be able to go back, and then they won't be able to bend forward. So they won't be able to bring their chin to their chest. Remember how I was talking about you might have issues with that whiplash, and if it's stuck in through the front, you're not going to be able to bring your chin to your chest because it would kind of make a kink in the tube of the esophagus or occlude the esophagus. Your body's not going to let that happen. If you bring your chin to your chest and you kind of feel like this kind of choking sensation in the front of your neck, it's probably an esophageal restriction that you need to be going after. Now, this is maybe something that you wouldn't think of. Stomach restrictions can cause left SI joint pain. Yes, the SI joint is in the pelvis, but if there is a restriction of the stomach, it can cause, more specifically, left SI joint pain. Now, how the heck does that occur? Like, what's the mechanism of that? So just try to follow along with me. Remember how I said that the bottom of the stomach is varied in terms of where it is on people? So if that lower part of the stomach is scarred down to be further down into your abdomen, and if you think about it, if it's stuck down there, and if I'm talking about how thoracic extension or trying to back bend can be restricted on people that have stomach restrictions, that means that there's not any motion really happening from that bottom of the stomach all the way up into your neck. And so trying to kind of go into back bending or leg extension, that mobility is not going to be evenly dispersed through all your spinal segments. Instead, it will be localized in a few areas. If you go back to my hypo versus hypermobility, I think this was the root cause of your pain, part 1, when I talked about when you have these areas of hypomobility, not enough motion. So that would be from kind of lower lumbar up if you have this stomach adhesion. Then you'll have hypermobility elsewhere. So hypermobility is too much motion. So what you might find is that if you're struggling with this left SI joint pain that just doesn't seem to be going away, it could be that you have this restriction of your stomach that is causing your SI joint to be hypermobile and move too much. And usually it's the site of hypermobility that causes more pain than the area of hypomobility or not enough motion. So this is that whole leak through the ceiling analogy that I talk about, that, injuries are like a leak through your ceiling. That ceiling tile or the water dripping down is a site of pain, but water didn't just magically appear in that ceiling tile. It wasn't made within the ceiling tile right there, then extruded out. No, it came from someplace else. You had to find the leak. So it could be that left SI joint pain that you cannot get rid of, it could be because you have a restriction of your stomach and it's causing this hypo versus hypermobility problem or dysfunction. So yeah, it seems a little crazy, but trust me, it's really cool when you actually start to get that mobility back and to see when you kind of swing your leg forward and back, how you're not going to be so much motion into your lower pelvis, but you're actually going to see the curvature happening in through your lower back and hopefully all the way going up into your thoracic spine as well. So fun little thing that people don't really realize that it could be a stomach restriction for that left SI joint pain, because let me tell you, there's a lot of people that suffer from SI joint issues. So now that we know what can happen if you have a stomach restriction, which I'll just briefly go through again. So pathology, things like more medical stuff, if you have a history of whiplash, ulcers, or acid reflux, you might want to be mobilizing your stomach and esophagus. More from a musculoskeletal standpoint, if you have limited left shoulder range of motion and you also have limited neck and thoracic or kind of like that mid-back range of motion, or left SI joint pain, it might be your stomach that might be the culprit. So how do we treat it? How can you yourself go ahead and treat that area? Well, in most cases, what needs to happen is that the stomach actually needs to come down, that it's held too high up. There's a shortening of that esophagus. And so a lot of people feel better when you're actually mobilizing the stomach down. So how can you do that on yourself? Well, let's talk about that lesser curvature. Remember that lesser curvature was kind of the right side of the stomach. And so it's a little bit more towards the middle. Now, if you were to look at yourself in the mirror and see where the lower part of your ribs are and how they kind of come up in the middle in the front of you to a kind of a point. So you have almost like it creates a triangle effect that goes to your sternum or your breastbone going up through there. So if you were to feel that point where both sides of your ribs come together at the lower part of your chest, of the breastbone, you would feel that with your index and kind of middle finger. And then you would follow that line down to the left about an inch or an inch and a half. That's it. So you would feel for the breastbone point in the middle, go down that lower border of your rib cage on the left-hand side about an inch and a half. And here's where I actually like to use my thumb. So even though I had you feel it with your index and middle finger, because usually you have more sensitivity with those fingers, and that's why I say feel it there. You're going to have more sensory input. Then you're going to, where your index and middle finger were, you're going to replace them with your thumbs. So both of your thumbs, and you want to have your thumbs going like they're touching end to end, and you want to be able just to lay your palms onto the rest of your abdomen. Then what you're going to do is you're going to sink your thumbs back into you. So you're trying to go back to the back of you about another inch and a half as well. And then you're going to feel like there's something muscular underneath your fingers, underneath your thumbs, the pads of your thumbs. So with that, you're going to sink back, and then you're going to lightly pull down with your thumbs like you're trying to pull down towards your left hip. Because remember, that esophagus is it starts in the center up in your neck, but then it goes off to the left-hand side. So if you're pulling down to your left hip, you're going to be stretching the esophagus more effectively and stretching that stomach more effectively. So you're going to pull down with your thumbs, keeping that inch and a half depth going down towards your left hip. And while maintaining that downward motion, which you might feel a little pull into your throat right now. If you have a really bad restriction of that esophagus, you might feel a little pull and tug in your throat. So you're going to hold down in through there. And then what you can start with is that you could either just start with lifting your head up and kind of going into extension and trying to look back behind you. See how that feels. See if while you're maintaining that downward force with your thumbs, if you feel any sort of stretch there. If you're not feeling as much, then you can kind of bring your thoracic spine into it. So then you can go into a little bit of extension, trying to back bend your spine while still pulling down. So don't come off that pressure going down into that left hip, mobilizing that stomach. You're going to kind of go up and back and just kind of relax and go rock back and forth as I'm doing it right now as I'm trying to talk into the microphone. You just want to rock back and forth, just always pulling down towards that left hip. And you'll start to feel that your thumbs want to kind of slide down your stomach a little bit. Not a lot, but you'll feel it start to slide down. That's your stomach starting to slide down. That's that fascia that you're starting to mobilize going down into your left hip. And it should feel good. The best way that I can say how it should feel, and maybe it's just because I lived in the Northeast, it's like when you're seeing the candy machines pulling taffy. The best way to think of it is just kind of gummy and just kind of stretching because the stomach's really muscular. And so what you're just going to feel just kind of the stretching of those strings. It's stretching and then pulling of that taffy. That's the best way to be able to visualize what's happening here. So I don't want it to be that your thumbs are actually sliding down your abdomen down towards your belly button. They should kind of stay in that same sort of place, but you should feel that when you go into that extension through your thoracic spine or through your cervical spine, through your neck, that you feel that stretching and the pulling of the taffy. So that's how you kind of get your stomach down. And like I said, for most people, that's what they need. They need to pull their stomach down. Now, what if you're one of those people that the stomach might actually be stuck down, the bottom of it stuck down too far and you need to lift it up? Maybe you're having that low back pain, that left SI joint pain. What should you do? Well, you should lie on your back and have your knees bent, feet flat. And what you're going to do is you want to feel for the mobility, how far you can move as you try to arch your back. So try to pull your lower back away from the ground and then flatten it out. And you kind of want to feel what sort of mobility you have there. Like, what's the range of motion? Does it have any pain with it? Is it restricted in any way? And then what you can do is you can feel for the point in the front of your pelvis on that left-hand side. That's what we would call your ASIS, anterior superior iliac spine. It's way easier to say just the pointy part of your pelvis. So you're going to go to that level on that left-hand side. And what you're going to do is you want to think about trying to do like a karate chop into your abdomen. So you want to have the pinky sides of your hands going perpendicular into your abdomen. You want to have your right and your left side because you want to try to capture that whole part of the lower part of your stomach. Now, don't be worried if this isn't actually the lower part of your stomach. Just doing a gentle mobilization here, you'll start to get mobility, so it's fine. So go just at the level of that pointed part of your pelvis. You're going to put your hands perpendicular into your abdomen, kind of the pinky side digging into your abdomen. So you're going to go sink down like an inch, inch and a half, two. If you can't tell, inch and a half is kind of your guide for all of these things. And you're going to pull up towards your head, and you're going to hold that upward motion while you're going to arch and flatten your back again. Just arch and flatten while you're pulling up with your hands. And if there's a restriction here, you'll feel it when you start to arch your back and you're still pulling up on your hands. You'll start to feel the restrictions there. You'll start to feel a tension and pulling. And same thing is you're going to kind of want to feel a little bit of that pulling taffy feeling as you're pulling up on your stomach. And so when I say you do this, like you're going to do it for like 30 seconds. It's not a long time because you don't want to do too much in the abdomen. Those vital organs are a little sensitive. And if you have a lot of restrictions, you're going to be really sore from just doing this. So it's not very long. It's like 30 seconds to a minute you'd be doing these exercises and like once a day. It's not something you'd be doing multiple times a day. So that's the two ways. So I'm not going to talk about going right to left, left to right. That's a little bit more hard to explain. And honestly, it's not needed as often. You're going to get a lot out of your kind of mobility and improving that fascia around your stomach if you try to pull down on it and then you try to pull up on it, just getting that whole stomach to move up and down. So a fun thing would be to do is to whatever it was that I said that could be a pathology, more like that musculoskeletal dysfunction. If it's more the thoracic extension or is it your shoulder range of motion, test that out first and then do these mobilizations and then retest. And be interesting to see if any of you have improvements of whatever it was that you tested. And most likely you are going to, because that is a big part of the missing piece of the puzzle for a lot of people still struggling with dysfunctions of these areas is the viscera and getting the fascia to move around there. So please let me know if you had any improvements by treating out your stomach. And tune in next week. We're going to talk about the liver and the gallbladder. Thank you for tuning in to this episode of the Body Fusion Therapy Podcast. Please share it with your friends and family, as well as leave a review if you liked what you heard today. We're looking forward to continuing this journey of looking at the body. Tune in next time.